Hello, I'm Dr. Mark Noar, and I am a gastroenterologist, a clinical gastroenterologist. And we're going to talk about electrogastrography. The importance about electrogastrography, or EGG, is that it is a tool that now allows us to define subsets of disease. Why is that important? And that is important because it's called personalized medicine. We can more personalize your diagnosis and therefore personalize your therapy and talk about actually curing the disease. So today we're going to discuss defining patient subsets of disease in endoscopic therapy and how this gastroenteric therapy can determine success versus failure using electrogastrography. It's important to begin with the basics, and we're going to start talking about the gastroesophageal axis. It is an interrelated, integrated coordination of motor function, which is influenced by multiple factors, and that therefore results in the normal conduction of fluids and solids from mouth into the intestinal tract. There are a number of different factors when we talk about the esophageal gastric axis. There are neurogenic factors, such as the efferent and afferent parasympathetics, typically of the vagus nerve, as well as intrinsic gastric pacemaker function. There are also hormonal and biochemical factors, and there we're talking about the body generating things like cholecystokinin or gamma-aminobutyric acid or ghrelin, all of which have feedback loops that also affect motility. And finally, there are anatomical factors that we have to account for, including structural alterations or inflammatory conditions that can affect how the motility works. The most important thing when we talk about motility is the interstitial cells of Cajal, or for short, the ICCs. These are the interfaces between nerve and muscle cells and the key to motility. So without the electrical conduction system, or the ICCs, being intact, then the nerve impulse cannot go from nerve to muscle and result in a contractile wave. We'll measure these things using the electrogastrogram, or the EGG machine. The EGG machine is a very simple device. It consists of a monitor with a standard computer on a stand with its associated keyboard and mouse. And then there is also a respiratory belt that attaches around the upper portion of the chest of the patient so that the device can sort out respiratory frequencies, as well as electrodes that will attach to the patient's abdomen, and the human interface device, which is the brain of the system. The human interface device then takes the images, or rather the electrical images, coming from the electrodes and pipes that into the computer while filtering it so that we have good signal, resulting in what you see here, which is an image of lines across the screen, giving us an actual electrical imprint of what's happening in terms of contraction of the stomach. As you can see here, the belt is placed above the breast level and secured tightly, but not too tight, around the upper chest. The electrodes are placed in 3 positions: 2 centimeters below the right midclavicular line, below the xiphoid process, and below the left midclavicular line. And this forms a single channel. What we're sensing here, as you can see in this particular slide, is we're sensing the movement of the typical contractile waveform from the upper body of the stomach across through the main body of the stomach and then into what we call the antrum and the duodenum. And we do that by this lead placement. It's important to understand that the waveforms that we are trying to elicit, or rather sense, begin as a circular contraction around the upper portion of the stomach at the proximal junction of the body of the stomach with the fundus. And then once that circular waveform begins, it then causes subsequent propagation down the wall of the body of the stomach in a longitudinal manner to the antrum and then out into the intestinal tract. When we talk about electrogastrography in disease, what we have learned in the past number of years, the past decade or so, is that it has a very important role when we talk about very common diseases such as gastroesophageal reflux disease, gastroparesis, and obesity. And we're going to cover each of these 3 topics today. When we talk specifically about gastroesophageal reflux disease And the emptying activity of the stomach, as well as the gastric myoelectrical activity, and it is the gastric myoelectrical activity that we're measuring with the electrogastrogram or EGG, this forms the basis of how we perform a standard water load test. This has been standardized for more than 20 years now, using a specific water load with the patient in a reclining position, measuring the contraction of the stomach. And this gives us two very important features that are important in understanding how the stomach motility works. One is the actual motility, or the contractions or waveforms, and then the other is compliance, which is to say the distensibility of the stomach. And it is that volume of water that tells us about compliance, which is very important in understanding disease. Typically, when we look at a group of normal patients who do not have reflux disease or other issues, or gastroparesis, we know that they can drink approximately 590 to 600 cc's or milliliters of water in a 5-minute period of time without any difficulty. This would be considered the normal compliance. However, when we look at patients who have disease such as gastroparesis or reflux disease, among a few, we find that those patients drink significantly less. And what we're talking about is, instead of that 600 cc's of fluid, we're talking about approximately 430 cc's, in that 400 to 450 range. We also know that the importance of the water load test is you need the water loading or the distension of the stomach in order to bring out the actual rhythm or frequencies when the stomach contracts, because those frequencies run from 1 cycle a minute all the way up to 15 cycles per minute. So if we look at the normal patient population, we would typically see the typically normal 3 cycle per minute activity that we're looking for runs about 58%. And then when you stimulate the patient and the stomach begins to distend under the force of the water load, we see a decrease in the normal 3 cycle per minute activity, and then more bradygastria, slow rhythms, tachygastria, faster rhythms, and then sometimes a mix between the brady and the tachygastria, again brought out by the water load. So that's the importance of the water load test. As you can see here, this is what we consider a normal electrogastrogram that occurs as a result of the water load test. In each of these 4 small diagrams, you will see broken dotted lines, and these represent population-based normals. This is 30 to 40 normal patients who were tested on multiple occasions, and so we know what the normal range of 3 cycle per minute activity is. We know what the normal range of bradygastria is, tachygastria, as well as a mixed or a respiratory level of contractility. As long as the patterns remain in between those broken dotted lines, we know that that is what consists of as normal. We call those normal. Now, when we want to look at pathology, this is an example of the bradygastria type pattern, and you will notice here in this particular box that we are considerably above the normal broken lines as a result of the water load test. Similarly, if we look at mixed dysrhythmia, you will see in this particular figure, not only is there increased bradygastria above the normal broken lines, but there's also increased tachygastria, and this is very common, and we see this a lot in the refluxing patient. Finally, there's another pattern known as tachygastria, where it's in the higher frequency we see the stomach begin to almost overcontract or overly react, almost like fibrillation with the heart. Now, what's really interesting about the electrogastrogram, and particularly in the refluxing patient, is because we're water loading the patient, and because it's the lower esophageal sphincter that's really defective, when that lower esophageal sphincter relaxes abnormally, we call that a transient lower esophageal sphincter relaxation, we have 2 interesting things that take place on the pattern of the electrogastrogram. We have a precipitous drop in the normal 3 cycle per minute activity, as you see here, accompanied by an instantaneous sudden increase in the bradygastric pattern as the stomach collapses and there's no further contractility because of the venting up into the esophagus. And again, we see this very dramatically when we do the water load test. Let's talk about some of the basics about gastroparesis as well as reflux disease that becomes important to see how electrogastrography fits in. First of all, GERD, or reflux disease, is probably the most common gastrointestinal disease that we treat. Approximately 40 to 45% of reflux patients have a concomitant gastroparesis, and about 50 to 60% will not have gastroparesis, but just have some dyspepsia. What electrogastrography does is it helps to detect the gastric myoelectrical activity in these patients. And this is, of course, dependent upon the quality and the quantity of the interstitial cells of Cajal, and this has been demonstrated in biopsy-based studies. And we know that you have to have at least 5 interstitial cells of Cajal per high-power field in order to have normal electrical conduction and normal contraction. Now, what we've learned is that dyspepsia and gastroparesis that we're talking about now can be subtyped based upon the types of ICCs or amount of ICCs that we detect on an electrogastrogram as it reflects on the overall gastric myoelectrical activity. There are different types of gastroparesis that we've found, and one of them is an obstructed type of gastroparesis that actually is known to cause reflux disease. That's always one of the big questions of what comes first, the chicken or the egg. And so is it gastroparesis causing reflux, or is it reflux causing gastroparesis? So in the case of the detection of obstructed type gastroparesis on the electrogastrogram, we actually know that that is probably what's causing the reflux disease, and by treating that, we can treat the reflux disease more directly. On the other hand, the non-obstructive type of gastroparesis, this is the type of gastroparesis that is caused by reflux. And the key point there is when we find a non-obstructive pattern on electrogastrography and the patient has reflux and gastroparesis, we know from published studies that by correcting the reflux disease, fixing the faulty lower esophageal sphincter in particular, the gastroparesis will spontaneously self-correct. A big question comes, well, what is the mechanism of action? How does reflux relate itself to gastric dysmotility or gastroparesis? I wanted to take a moment to explain that to you. Reflux usually results in an abnormally increase in the venting of gastric contents into the esophagus because of a faulty pressure in the lower esophageal sphincter. What this does is that results in the loss of the gastric yield pressure. The gastric yield pressure is very important because you have to be able to build a head of pressure in order to be able to contract the food from the top of the stomach down to the bottom of the stomach and out into the intestinal tract. That gastric bolus is typically carried in the fundus above the level of the gastric pacemaker. And so with venting of the pressure of the stomach into the esophagus, the bolus cannot move out of the fundus, and therefore the gastric contents remain in the proximal stomach, literally above the level of the pacemaker, and cannot be conducted into the distal stomach and antrum, and that subverts the normal contractile response. What this does is it causes a delay in gastric emptying as well as symptoms of nausea or bloating, things we call dyspepsia. In this particular case, when we define the disease in this manner, we know that by correcting the reflux and stopping the venting into the esophagus, the food bolus can then be pushed down lower where it can be captured by the gastric slow waves and moved into the distal body and then subsequently into the antrum and the intestine. There, you then have the resumption of normal contractility and gastric emptying. Here's an example of a patient who had reflux disease. And this patient was going to have a reflux corrective procedure that's known as radiofrequency modulation of the lower esophageal sphincter. In this particular procedure, we use radiofrequency energy to stimulate the sphincter muscle to grow. And when the pressure increases, then you have no further venting. When this occurs, then there's no further reflux. So in this left side of the slide, as you can see here, this is in the pre-Stretta patient, you will see that there is very little normal 3-cycle per minute activity, and in fact, there's a lot of tachygastria in this particular patient. If we come back to that patient several months later, the reflux is now better, and the first thing you'll notice is there's a significant improvement into the normal range of the 3-cycle per minute activity because we've recreated the normal situation for gastric yield pressure. The tachygastria goes down back into the more normal range, and the bradygastria, which was subnormal, has now returned into the, again, population-based normal range. So this is an example of how we can correct the dyspepsia or the abnormal rhythm by fixing the reflux. This particular slide is a different depiction of the same thing. Over a longer period of time, you can see all of the frequencies depicted in this upper diagram here. And this is in the pre-correction of reflux period. And you can see quite a lot of disorganized waveforms extending across the entire spectrum, as opposed to centered in the 3 cycle per minute activity range that we want to see. With correction, notice how that has now all completely settled out, and there's no further tachygastria in the upper range, and we have more 3 cycle per minute activity. This is that same patient, but just seen in what we call a running spectral analysis. Now, we would expect that by improving the gastric yield pressure and then improving the contractility of the stomach, then a pathological condition such as gastroparesis, where we know things empty slowly, would also correct itself. And in fact, when we studied that, looking at patients pre and post correction of reflux, as you can see in this slide, the gastric emptying baseline at 90 minutes in terms of percent emptying was very abnormal. A significant improvement in that emptying now at 8 months after the correction of the reflux. So not only do we know that we're improving the contractility, but we also know that by improving the contractility, by fixing the reflux, we also cause that normalization in gastric emptying. In this particular slide, this is yet another depiction of the same thing. The difference is that we're looking at the percent emptying at 90 minutes on the left-hand side of the bar graph and the percent emptying at 120 minutes. And you can see that in the post-correction of reflux period, a significant improvement in 3 cycle per minute activity in these patients and improvement in their gastroparesis. If we look at the EGG findings, we also see similar improvements. So with regard to the normal EGG 3 cycle per minute activity, only 27% of these patients had normal activity prior to correction of their reflux, that then increased significantly to 51%. And this was accompanied by also significant improvements in the tachygastria, going from 47 to 31%, back into the normal range, and the bradygastria also dropping from 11% down to 4%, again, back into the normal range, all with correction of reflux, with the aid of the electrogastrogram documenting that the gastroparesis was due to the reflux. Now, of course, the most important question, or one additional question that's often asked is, well, you've demonstrated objectively that there's an improvement in the electrogastrogram. You've demonstrated objectively that there is a normalization in the time of gastric emptying, but does that actually translate into the patient feeling better? And that is the most important question that was posed by the American College of Gastroenterology in order to determine if electrogastrography is truly valuable in clinical use. And what we've been able to answer, again, looking in this refluxing group, is that not only does the electrogastrogram improve, not only does the gastric emptying normalize, but as you can see here in this slide, the dyspepsia scores, the nausea scores, post-correction of reflux, also concomitantly improve significantly, and this is over a 24-month period of time with a very, very significant p-value.